proud to be associated with him and assisted in the Karimnagar State Conference. And he's also one of the guest faculty for the next upcoming conference in Karimnagar. A warm welcome to you, sir. Please join us, and please go ahead with your seminar on radiology of PNS. Thank you so much, sir. Ramesh, carry on, Ramesh.
Yeah, thank you, sir. Thank you, sir. So, warm welcome to Sathish Jain, sir, to start our first session. You are the opening batsman for our new academic series, sir.
Ramesh, sir is there on the line?
Yes. Harsha?
Yes,
Harsha.
he's there, sir. He's connected.
Yes, sir. Yeah, you take care of all the technical issues. Thank you, Sriharsha.
Hello.
Sir, good evening, sir. Warm welcome,
evening.
sir.
Welcome, sir.
Good evening, sir. Good evening.
With a single call only, you have accepted our request, sir.
Thank you,
Once
sir.
again, thank you so much, sir.
We're missing you so much, sir. Thank you, sir.
Pleasure is mine, sir.
Thank you so much.
So, am I audible?
Yes, sir.
Yes, sir. Please go ahead, sir.
Please go ahead.
Before we start, I think we have not started the telecast. Is it?
Sir, we are about to. I think we are, sir. Two more minutes.
2 more minutes, no?
Yeah, just
Yes.
1 minute only, sir. No problem, sir.
Let me check whether I am able to share my screen or not.
Yes, sir.
What are you getting on the screen?
Yes, sir. We are PNS pictures, sir. Radiology.
Is it dynamic?
Yes.
Yes, sir.
Dynamic. Okay. Now, are you getting? What are you getting now?
Yeah, we can see the arrow on the osteometal complex, sir.
This is PowerPoint now.
Yes, sir.
What are you getting? The same DICOM or PowerPoint now?
DICOM only, sir. No PowerPoint yet.
That's what I wanted to check because now I have to. Now
we are getting the PowerPoint now, sir.
Yes, sir. We got it.
So every time I have to stop sharing and then come back.
Sir, you can instead share your desktop, sir. Screen. Just share screen instead of the application.
How to share the screen?
Sir, when you click share,
Yeah.
you see an option called screen. Just screen, not the application. Share entire screen. Yes, sir. Yeah, this one, sir. Yes.
Getting now?
Yes, sir. Now you can alternate, sir, between yes, both are coming.
Now what is coming?
DICOM.
And now?
PowerPoint presentation.
No.
Fantastic. So from my side, I am done. Hello.
Yes, sir. Sir,
So
Yes, sir. You can go ahead, sir.
please, sir. Please go ahead, sir.
Do we start now?
Yes, sir.
Okay. So first of all, thanks to the AOI Telangana team for giving me this opportunity and involving me for this important session. And as you all know, what I have been asked, I came to know there's a series of webinars you are going to organize now.
Yes, sir.
As Dr. Ramesh told me.
Yes, sir.
Yes, sir. Yes, sir.
Yeah. So indeed, I am grateful to Dr. Ramesh, Dr. Sudeep, the president, and the entire AOA Telangana team for involving me and giving me this opportunity to start this first webinar of the series probably.
Yes, sir.
So the topic given was radiology of the paranasal sinuses. It was supposed to be 2 sessions, 1 hour each. but I requested them to club them together. So this is 2 hour session now. So we'll discuss all important aspects of radiology. We all know radiology is not our, prerogative, not our subject, but this is something on the surgeon's perspective I am going to talk about. So we'll discuss some important aspect of radiology from surgeon's point of view, what surgeon actually needs, what we can extract most out of radiology, what we can extract most out of the radiological information, how we can, involve our radiologists to give us more and more information, what kind of sequences we need, where is the onus to order those sequences. So lot many things we need to know about the radiology to get more and more information. We all know radiology is technology basically, and this is the time of technology, and the advancement in technology is much more than the advancement in surgical technique. It is much faster. So this is basically to take the advantage of, or the optimum advantage of radiology into surgeons' surgical planning and surgical execution. This is what I'm going to talk about. And since paranasal sinuses are important areas, they are closely related to the skull base, orbit, and many other vital structures, critical structures. So the important thing is to know complete three-dimensional anatomy of the sinuses and beyond, and what CT scan, MRI, which particular investigation is useful for particular indication, what particular sequences are needed to get optimum information. That is the basic aim of this talk I am going to discuss about. So as I said, our radiology for the paranasal sinuses starts with the radiology for chronic rhinosinusitis. That is the commonest problem we face in our practice. We come across, that is chronic rhinosinusitis, and this is a benign inflammatory disease we all know. And the role of radiology in this situation is basically directed towards getting more and more three-dimensional anatomical information rather than diagnosis. Many of these patients either having polyp or non-polypoidal sinusitis. Most of the time you get diagnosis by means of ongoing symptomatology. The criteria for diagnosis are basically clinical based on the symptomatology. Then you can take the help of endoscope showing you the mucus, purulent discharge, or the polyps coming out of the paranasal sinuses. That gives you a confirmed diagnosis of the disease. So the role of radiology is basically to facilitate the surgical planning. To know the extent of disease as well, as far as the surgical planning is concerned, the extent of disease is very, very important. Characterization of the disease, what kind of disease, whether it is fungal, non-fungal, in benign diseases, in malignant, benign other diseases, we need lot many other information from the radiology. Then all anatomical structures, the key anatomical structures need to be identified thoroughly on radiology, not only in single plane but in multi-planar fashion in all planes, so that we get three-dimensional information of the particular important anatomical structures and around them. Then the anatomical variations are very common in the paranasal sinuses, we all know. And being surgeon to work in that area, we need to be fully, aware of the anatomical variations. Sometimes they are very, very critical, going to the critical structures, like on the carotid artery, optic nerve. We need to be very much aware of all those anatomical variations, and this is what the radiology can give you. And in certain situation, if complex the situation is, you can, plan an image guided system, and in that situation, the radiology has a very, very important role in planning the, the need of image guided situation. So the first question comes when we talk of the CT scan of the paranasal sinuses, that what kind of CT scans we should order to a patient when patient comes to us. This is very, very important. The most important aspect of this, session today is the kind of radiology we must order to our patient to get optimum information. What happens otherwise? you write CT scan PNS. And what happens? Patient will go to a diagnostic center and get a CT scan PNS done. And that can be done in a simplest manner in few seconds with a 5 mm section, 4 mm sections, and patient can come back to you with a film, a single, double or triple film, whatever. Each film contains 12 to 20, 24 slices to a maximum of 70, 80, 100 slices. That is a fixed printed report, slices. Is that the optimum information you are trying to get? Big no. So what kind of information we can get maximum from the radiology and how? So this area of the paranasal sinuses basically from top to bottom is around 20 centimeter. You can say minimum, right from frontal sinus to the floor of the maxillary sinus and little beyond. Similarly, medial to lateral is more than 20 centimeters. Similarly, anterior to posterior is again more than 20 centimeters. So to get this three-dimensional information of 20 centimeter all around, 20 centimeter means 200 millimeters. We all know paranasal sinuses are fine structures. Even some millimeter, information can change the scenario for the surgeon as far as the complication avoidance is concerned. So to get complete ideal information, we need to have some millimetric section. Like for example, in this patient, in this particular section, you can see 0.7 mm sections. That means if I run this CT scan, every time I'll jump by 0.7 millimeter. Anything between 0.7 millimeter still I can skip. But that is not so very important in paranasal sinuses. If I get 0.7 mm scans, I really don't miss any single anatomical information, critical anatomical information. So the kind of information I'm going to get with 0.7 millimeter in a 20 centimeter area, that means 200 millimeter. How much slices are going to be? How many slices are going to be? More than 280 slices. See, this is 376 slices I am getting out of this axial sections. You know, the paranasal CT scan is shot in axial plane. So in the axial plane, if I go from top to bottom, see right from the head, top to the bottom, below the floor of this is maxillary sinus, I'm going upside down. This is the kind of area the CT scan was shot into. So I have 376 slices which can't be carried in a printout. If I happen to carry this 376 slices, I need at least 20 reports, 20 printouts. Now, what else I get out of this dynamic CT scan? See now, I can get information in all planes. 376 into 3.
Sir, can you share your PowerPoint, sir?
PowerPoint? Are you getting the... What are you getting on screen?
No, you have not shared your screen, sir.
Not yet?
Yes, sir.
Oh my God. No. Sorry. I thought I have shared the screen. Sorry. Let me know when you get. Are you getting any screen?
Yes, sir.
Now?
Yes, sir.
What are you getting now?
DICOM picture.
DICOM. So what sorry, I thought I was sharing. Thank you for, informing. So you see this 0.7 mm scan shot in axial plane. CT scan is for the paranasal sinuses is shot in axial plane. And how much slices you have? 376. So right from top of the head to below the floor of the maxillary sinus. See this? Below the floor of the maxillary sinus, I am getting the CT scan in the axial plane with 376 slices. Are you getting now? Now, this is possible when I am getting in a digital format, in the DICOM format. So ideally, we should order our patient when we order a CT scan to get optimal information. CT scan paranasal sinuses 0.5, 0.6, 0.7, whatever your available machine can give you, 0.5 mm sections in DVD in the digital format or in DICOM format. The advantage is you get complete slices with you. You can see all fine details everywhere, that too in dynamic fashion. And then you can, with the help of this software, DICOM, you can reconstruct in all three planes. See this? Wherever I am running, I can see in all three planes. If you see in sagittal, this is frontal sinus, you can take your cursor and see frontal sinus in all planes. I hope you are getting what I'm trying to say. So this way you get complete information about that particular three-dimensional area. See this, I want this area, this right from the anterior part of the nose to the behind the frontal sinus, right from top to bottom, right from anterior to posterior in all three planes, that too in dynamic fashion, which is impossible if you want to have in printed format. So we must order our patient always to get this information in the digital format, number one. Number two, we must order fine section, otherwise radiologist or a technician can do 5 mm section in a second's time to save the slices. The CT scan machine, run on the basis of number of slices. The less slices you make, more machine runs, and the technician or the diagnostic center can save a lot of money out of preserving or giving you less slices. So you need to ask, you need to order in your prescription when you order a CT scan that you want a submillimetric section in DICOM format to get complete information. Not only complete information, but dynamic information as well, so that you can better understand any structure in three-dimensional planes. See this Agarneji cell, if you see, you can see in all planes. See, this is your nasal septum in all planes. This is orbit in all planes. This is your every structure you can see in all planes. This is like your nasolacrimal duct in all planes. So you can have a better understanding of radiology in all planes if you have this information in the DICOM. Number one, this is most adequate information which actually you want to get optimum information. Number three, like for example, any important structure if you want to see, this is post-sigmoid. You see post-sigmoid in all planes. So that is so important information which you can get in all planes, and that is possible only if you order the CT scan in a DICOM format. The sphenoid sinus you can see in all planes. So every information you get dynamic, and this is a very good teaching tool in the institution for the students as well. The students can download this software on their laptop and run the CT scan and learn reading the CT scan in all planes in the easiest way. The more and more they practice, the easier it is for them to understand the three-dimensional anatomy. This is number one. Number two, besides this, sometimes you get more information in different window settings, like soft tissue window, bony window. Like for example, let me show you what is the difference. This is bone window, what I am running. This is bone window where you're getting the bones very clear, prominent, and the soft tissues are not giving much information. Let me bring the soft tissue window now. Simultaneously. Now see the soft tissue, the muscles, everything. The bony information is not as per the mark, but see the soft tissue, see the optic now, see the globe, see the muscles all around. This is soft tissue window, see the brain, and you can see much better details of the brain as compared to the bone window setting. So you get in the DICOM format the soft tissue window also in the same plane. You can get in three-dimensional plane all the soft tissue window. See, these many slices are impossible to carry in printouts. So bottom line is always order the CT scan in digital format to get optimum information. And you will need to know which information is gained based from which plane? Axial, coronal, sagittal. Like certain structures are best delineated in the sagittal plane, certain in axial, certain in coronal plane. So we need to know which structures are better appreciated in which plane so that we can get more optimum information. Now, secondly, about reading the CT scan. You know, you order a CT scan and you get finally a radiologist report for a sinusitis patient that the patient has bilateral pansinusitis. That's it. What does it mean? We'll know this. The patient has a bilateral pansinusitis by and large. What all we need is a detailed anatomy in three-dimensional planes. The more and more anatomical information for which the CT scan is ordered. A, a radiologist, for a radiologist, I know it's not about the possibility. It is so cumbersome. It is, believe me, next to impossible for a radiologist to give you each and every anatomical detail that may take him hours and hours, which is relevant to the surgeon. It is not the diagnosis that pansinusitis which is important. The important thing is the anatomy. And even if the radiologist give you anatomy, for example, radiologist can give you the middle tabinate, the cribriform plate is like this, there is Agarnagi, there are T Agarnagi cell, there is frontal cell. Still it is as good as useless for a surgeon, because for a surgeon who is going to operate in that particular area, himself should know the three-dimensional relationship of that particular structure. For example, see my cursor where it is. This is the uncinate process. I need to know how the uncinate is going up. See where my cursor is, and taking a lateral turn to attach on the lamina papracia. I should know how the bulla is, how big the bulla is, how the relationship between the bulla and the uncinate. What is the distance between the medial wall of the orbit and the uncinate. Every single detail in terms of some millimetric, details cannot be given by a radiologist. We tried out this. We gave our radiologist a format consisting almost 400 points. That how the Agarnagi cell, how the frontal intersinus septal cell, this cell, deviation, nasal septal deviation, turbinate, uncinate, bulla, orbital details, so many things. Carotid artery, type of pneumatization of this sinus, that sinus, more than 400 points. It is next to impossible for a radiologist to fill up all those information and give you the complete detailed report. Huh? Hello, are you getting my screen?
Yes, sir.
Yeah.
Yes, sir. Yes, sir.
So,
Yes, sir.
so for a radiologist, it is next to impossible to give you information of each and every small some millimeter detail on your report. It may take hours and hours for the radiologist. Number two, even if we give, it is as good as useless, because we need to know ourselves the three-dimensional anatomy which we are going to face surgically. So the onus is again on the surgeon to know how to read a CT scan, PNS, and what all important information has to be acquired from a CT scan, PNS. Any questions, anything? Please feel free to interrupt me anytime. Hello?
No, sir.
Hello?
We can hear you, sir.
Yeah. Okay. So feel free to interrupt me anytime if you want.
Okay, sir. Okay, sir.
So most of the information in radiology or the paranasal sinuses, what you get from CT scan, we get from the coronal section. Coronal section is more easier to understand because we operate in the same plane, and the CT gives you the anatomical orientation in the same plane. And quickly, if I show you what all need to be seen on a CT scan, you see right from anterior to posterior. Quickly, first what you see after the scalp is the frontal bone. Can you see this? If I go behind, the next structure what you come across in this section, what is this? The nasal bone. And what is this? The frontal sinus pneumatizing the frontal bone. See this? Pneumatizing the frontal bone. There's the nasal bones on both sides, the internasal suture, and two See this, the frontal sinus, this is intersinus septum. Why it is, I am calling this intersinus septum, not the others one, but those are incomplete septations and the scallopings you can see. The true nasal intersinus septum is going to go all along, right from beginning till posteriorly. See the intersinus septum dividing the frontal sinus in two unequal cavities. Frontal sinus, intersinus septum is never in the midline. It is almost always unequal. And you need to see the level of, pneumatization of the frontal sinus. This is very, very important in decision making. What I'm saying, every point has a surgical significance. That's why I given this title as a surgeon's perspective. What all information is required from surgeon's, perspective from the radiologist side. So and why? See this is the intersinus septum. This is the nasal bone, and see the internasal suture, the frontonasal processes, the cartilaginous nasal septum, and the ala. That is what you see anteriorly. And we all know frontal sinus drains from behind, not anteriorly. So as you go from anterior to posterior, like see this is anterior, I am going posteriorly. This was nasal bone. And see as you go behind, what is there behind the nasal bone? If I go, this becomes the beak. This becomes the beak, and beak forms the floor of the frontal sinus. If I go behind, see the beak, which forms the floor of the frontal sinus. I am going behind, and where the beak ends is the frontal sinus drains. See this, as I go behind, the beak is ending, and now the frontal is draining. See this? Now no more beak, and the frontal is draining. Now what has gone in between? Now see quickly, I went fast, now see quickly what structures come while going from anterior to posterior. The first cell, the first pneumatization which comes as you go behind in the paranasal sinuses after the frontal sinus, the first pneumatization which comes is the intersinus septal cell. See this, sometimes they are multiple. See this patient, and this cannot be determined without a dynamic CT scan. I tell you this, I can guarantee you, by means of printouts, you can't make out this fine detail. See, as I am going behind, see two cells appearing. This is pneumatizing the intersinus septum. This is intersinus septum, and this is pneumatizing the intersinus septum. Two cells. What is the significance? Number one, these intersinus septal cells drains in either of the sinuses. And we need to know while operating that how these cells are draining into these sinuses so as to see them widen there and to ensure that there is no further disease is, remaining in intersinus septal. We have seen a couple of times fungus remaining there. And leaving a fungus which is like an antigen to inside the inflammatory process is something, ruining your results of the surgery and giving patient persistent symptoms. So, see now, as I go behind, there are two intersinus septal cells. See now, this one is opening into the right side. And as I go behind, see this, this one is opening into left side. How do we get to know? By means of this 0.6 mm. This is 0.4 mm. This CT scan is 0.4 mm sections, and every time I'm moving with a 0.4 mm, distance. Now see, this is frontal sinus this side. Before this, see the beak is intact. That means still the frontal sinuses are there. These are incomplete septations, intersinus septal cell, and now the beak has gone, and this is the frontal recess which has come into picture. Now this is no more frontal sinus, this is frontal recess draining into the, that is the drainage pathway of the frontal sinus. So frontal sinus is where the beak is. Let me show you in all planes. It is exactly what I'm trying to say, that so that you never get confused. I was going from anterior to posterior. You can see. See now. See, here I am going anterior to posterior, here I am going anterior to posterior. See where the process is going. Behind, and now the frontal sinus. And as you go behind, this is frontal recess. So here, in sagittal plane, you can see this is the beak. This is the thick beak, and where it drains is the frontal recess. See that? So that is how your frontal sinus drainage is established. And this is so important to understand. This is your beak, and this is the frontal sinus drainage after that. So this is one important thing. Some request is coming, annotation request. I don't know what exactly is that. So the important thing is how to look at the frontal sinus from anterior to posterior. Number one, how big, how pneumatized the frontal sinus are. This is very important. Sometimes in decision making, when you have a massive frontal disease, when particularly you have a revision situation. If you have a multiple revisions, we come across very often. In that situation, you have to take a call of either Lothrops or osteoplastic flap or something like that. For decision making, the pneumatization of the frontal sinus is the key factor. If frontal sinus is too big, too pneumatized, you are biased towards giving a internalization, that is drainage pathway, that is modified Lothrops or variety of any of the modification of the modified Lothrops, draft 2, 3, modified, central draft, whatever. But if you have a small sinus, frontal sinus, and you have multiple revisions, you can afford to remove the mucosa easily, because in large sinus it is difficult. That's why we are biased to give internalization. In small sinus, you can easily remove the mucosa and obliterate the sinus with a fat or something to give a permanent cure of frontal sinusitis to the patient. So a decision making is very, very important on the basis of the size of the frontal sinus. Sometimes we have patients with CSF leak from the frontal sinus, posterior table, skull base somewhere, and you can get very good information from multiplanar fine section CT scan where the leak is coming from, and what approach can be used. Yes, more and more CSF leaks from the frontal sinuses nowadays are being tackled by means of endoscopic approach, and here your CT scan anatomy will dictate you whether it is feasible by the endoscopic or not, or whether it is appropriate or not to do by endoscopy or to go ahead with the open approach. So that decision making is very important on the basis of the CT scan. Here we are talking about the chronic sinusitis. So here, after the frontal sinus, as you go behind, the orbit has started coming into the picture. Now in the frontal recess, see, when your beak goes, the cellularity start coming in the frontal recess. See the first cellularity. See the first cellularity which you are getting, in the frontal sinus, in the frontal recess. These big cells, these are what? Agar-Nagy cells pneumatizing the lacrimal process here, the lacrimal bone here, and that is the most anterior anatomy, and that happens to narrow the frontal sinus outflow, and we need to know this, the size and dimension and the type of Agar-Nagy cells, so that you can properly widen the frontal drainage pathway. Like for example, in this patient, this is so important. If you follow this radiology properly, three-dimensionally, the way I am sharing with you, see this Agar-Nagy. Now where the Agar-Nagy is, look into the sagittal plane. Look into the sagittal plane. This is Agar-Nagy cell. Why it is so important? The frontal drainage pathway is narrowed by this Agar-Nagy. Agar-Nagy cells are situated or attached on the anterior wall of the frontal recess pathway. See, this is frontal recess. It has the posterior wall, that is skull base, and the anterior wall that is continuing with the beak. So Agar-Nagy cells are attached to the beak. Why it is important to see in the sagittal plane in all planes? The reason is, in order to widen the frontal recess pathway, our approach is to go with a 70-degree telescope, insinuate your curate behind the Agar-Nagy and fracture it out anteriorly. That's it, to widen it completely. So easy it is a situation. if you think surgically, because it is attached to the anterior wall, and what you need to do is go behind and fracture it out anteriorly to give a full widening of the frontal recess pathway. That is how the agonage is so important to understand and so important to see on CT scan. There are a number of cells, in relation to the frontal recess pathway, and Kuhn has described, Kuhn has classified into variety of cells into type 1, 2, 3, 4, according to the degree of difficulty they are posing to a frontal sinus surgeon. There's a very, very clinical classification that how much degree of difficulty is being, given by a particular cell. So type 1 gives minimal difficulty to the surgeon, easier to tackle, and one can easily understand how the type 1 cell can be cleared off to widen the frontal sinus. So let me show you, in an easier way, I can show you. Yes. Yeah. See, to explain you in a better way, are you getting the PowerPoint slide, sir?
Yes, sir. Yes, sir.
Sir, are you getting the PowerPoint slide?
Yes, yes, sir. Yes, sir.
Okay. So in the frontal cell, in the frontal recess, there are a number of group of cells which are attached to the anterior wall. That is Kuhn cells, which I am going to show you. Type 1, 2, 3, 4 agonage cell. They are attached to the anterior wall. Then there are group of cells which are attached to the posterior wall. Posterior wall of the nasofrontal drainage. That is supraorbital cell. When it extends into the frontal sinus, it is called frontal cell. Recently in our workshop, I demonstrated one of the case of frontal cell, a large frontal cell giving frontal sinusitis. Then the supraorbital model cell, very important cellularity we need to understand. And intersinus also, you can't say and posteriorly, but you can, you have to be at the skull base to remove them. So now, what is the simple? This is agonage. See this? Agonage are attached to the anterior wall and the frontal drainage is behind. You go behind and get them out. See this agonage, variety of situation of agonage. Now Kuhn cells. See the type of Kuhn cells, the tier of Kuhn cells. Kuhn cells, when they have 1 or 2 Kuhn cells below the level of the beak. See, this is beak. Still below the level of the beak. See the tier of cells. 1, 2, 3, 4 cells, but still all below the level of the beak. The complication from type 1 is you need to remove the number of cells completely rather than leaving the cells behind to give fibrosis and again giving, obliteration. Third is, when the situation is little more complex, one of the cell goes high up in the frontal sinus. The complexity is now you need to go further high up and fracture the cell out completely. You can do it with a 70-degree and a long probe and J-curate, you can still get out it completely. Nowadays, more and more sophisticated instruments are available. You can use many of them to get the cell completely. With a 120-degree micro divider also you can use some time to get the cell out, and most of the time you get the cell out without doing any kind of draft procedure. And now see the type 4. Type 4 is much bigger cell, even ascending high up in the frontal sinus. You can say more than 50% height by and large. It's not hard and fast. Or the loner cell high up in the frontal sinus, and this is, you can understand, see the degree of difficulty to reach out the cell from all around and get the cell completely out. It is literally very, very difficult, and in that situation the things become easier if you drill away this beak, do a draft, drill away this beak simply, and you get onto the cell easily. And that is how these cells are being one can easily tackle. So in frontal sinus we need to know what kind of cell the particular patient is having, and we should know by means of all 3-dimensional CT scans so that we can get that cell completely out and give a wide frontal sinus drainage. The wide drainage is, whenever we talk of the sinusitis, nowadays sinusitis we all know is an inflammatory disease. It is not infection as such as a primary disease. It is inflammatory disease for which the steroid is the answer, and this sinus surgery gives us not only clearance of the disease the disease load, but gives us opportunity to deliver the topical steroids into the sinuses. And in order to deliver topical steroids adequately, we are supposed to widen the sinus, pathways widest possible, particularly the frontal sinus, which is situated strategically at a different angle, where delivering the topical, steroids is little more difficult. And we literally explain our patient to douche in a particular position, lying down, lying head back position, or something like, or head bending anteriorly position, whatever, so that the steroid can be introduced properly. And this widening of the frontal drainage pathway is very, very important in order to deliver the steroids inside. That's why the cellularity needs to be, if it is there, if you are dealing with a frontal sinus and this all cellularity is there, you are supposed to remove that and flush completely to the wall so that you can give widest possible pathway. So this is about the cells attached to the anterior wall. Now there are cells attached to the posterior wall. Now the thing is, the situation is altogether different now. The reason being, the organ is attached to the anterior wall, you can afford to go behind and fracture it out. But the cells, what happens? If the cell is attached to the skull base, can't afford to go behind. If you try to, you'll end up damaging or breaching the skull base. And this can be, this is not uncommon if you are not good at CT scan, if you are not thorough with the CT scan, and if you are not completely, three-dimensionally oriented, one can happen to damage the the skull base easily and get a CSF leak. And the best way is to run the CT scan in DICOM in 3 planes, get used to the particular anatomy you are operating upon that particular patient, and then choose how to carry out the dissection in that particular region. So for supraorbital cell, we are not supposed to go behind. And to avoid that situation, what we are supposed to do, we need to have a confirmed diagnosis, what kind of cell we are dealing with, and CT scan is the answer for that. And we need to flush the, punch out the walls of the supraorbital cell and flush with the skull base. If it goes inside the frontal sinus high up, then it is suprabular cell, a frontobular cell. Now see this, if the cell is going high up in the frontal sinus, see how much the frontal sinus can be narrowed with this kind of cell. And this cell going high up in the frontal, that to posteriorly attached, is a complex one. You use a 70 degree, which give you complete picture of this cell and get the septation out by punching them to a through biting or something curved instrument to get the cell completely out without damaging the skull base. So the posteriorly attached cells are important cells, and we need to have a clear-cut diagnosis whether the cells in the frontal sinus or frontal recesses are anteriorly or posteriorly attached. Another important cell is the supraorbital cell. Supraorbital, as the name implies, a cell above the level of the orbit. Cell pneumatizing the frontal plate, frontal bone above the level of the orbit, superior to the orbit, and these cells happen to lie behind the frontal sinus. Now, important thing is the diagnosis, that otherwise one can get easily confused with a supraorbital cell or a supraorbital situation. Like, for example, in the sagittal plane, it look like this. Now, let me run on the DICOM what the supraorbital cell looks like. See this. Are you getting the DICOM picture now?
Yes,
Sir,
sir.
are you getting the yeah?
Yes, sir.
So I am confirming while switching over, so that it should not go unchanged. Now see, in the frontal sinus, see this. In the frontal sinus, when you go behind, now the frontal sinus is over and the frontal recess starts. See this. Now, see this, the cell which is pneumatizing above the orbit. One can easily get confused with the frontal sinus, but now this is not frontal sinus. This cell is above the orbit. Frontal sinus we have already left anteriorly. We have come, see, this is frontal sinus anteriorly, we have gone behind. This is frontal recess, the frontal sinus is over, and what cellularity, what you see, sometimes it is pneumatized. We have seen this cell pneumatizing even the zygoma with the disease inside, full of disease inside. So we need to see how the supraorbital pneumatization is. This is very, very important. More the skull base is pneumatized in this region. See this region as a thin skull base, the anterior skull base, which is relatively very thin. And if there is high cellularity in this region, the skull base becomes much more thinner. The structures passing through the skull base becomes much more prominent. If you have a huge supraorbital cell, what you see next to the supraorbital cell is the anterior artery, and you most of the time find in such situations, see the anterior artery much more prominent as compared to the regular situation. So you have to be very careful while dealing with the supraorbital cell, that your skull base is less thinner, relatively much less thinner, and your arteries and neurovascular structures are much more prominent. So how to identify the supraorbital cell much confidently? Let me run in all three planes again. See this? All three planes. And let me see that cell. Let me show you again. That was my supraorbital cell. See this? See this supraorbital cell. Now see again. The same thing I am, bringing here. See this cell. This is supraorbital cell and this is frontal sinus. The supraorbital cell is behind the frontal sinus. We have seen it runs behind the plane of the frontal sinus. That is supraorbital cell. So supraorbital cell is always behind the plane of the frontal sinus. Let me give you a good example of the supraorbital cell. Let me give you so that you will never forget. Probably this one. Yes. Yes. I hope you are getting the diagram. This is not supraorbital. We again see. Yeah, this one. Let me know, sir, if you are getting the diagram now.
Yes, sir.
Yeah, sorry
Yes,
for
sir.
bothering you. The reason is
No, no.
I should not, screen
No,
should not
getting
go
it.
blank. Now see this particular patient. This is amazing example of the supraorbital cell. See the frontal sinus? This particular patient, look at the frontal sinuses. Now the frontal sinuses have gone. See the frontal recess. And see, I am going far behind. There's a cribriform plate. And see our supraorbital cellularity far, far behind and beyond. Can you see very clearly? I am going far behind. Even the cribriform plate has disappeared. See that this is the level of the cribriform which is disappearing. The posterior ethmoidal cell has come, and see the supraorbital pneumatization is still continuing. This large supraorbital pneumatization anterior to posterior. See how big this pneumatization is. Let me show you in all formats how big the supraorbital pneumatization is. See, these are some important situations we must not forget. Now see, I'm placing into this supraorbit. See this, right from the orbit anterior to posteriorly, all the way along the almost entire orbit, the supraorbital cell is. Your frontal sinus ends so anteriorly, and this supraorbital cell is running all the way, crossing the postethmoidal, almost completing the postethmoidal level. Till that, the supraorbital pneumatization is continuing. And this supraorbital pneumatization, if you see, in axial plane, again, see this? This posterior cell is supraorbital. So we must keep in mind the supraorbital is a posterior pneumatization. And you can take the advantage of the supraorbital cell as whenever there is supraorbital cell, your anterethmoidal artery, you can trace immediately behind that. Your anterethmoidal artery, you can always trace immediately behind the supraorbital cell. So again, I am coming to the same picture now. How to read the CT scan right at the level of the frontal sinus. See this? That's the frontal sinus, frontal recess. This was the supraorbital cell. So Another, I can give you one more clue whether it is a frontal sinus supraorbital, because sometimes this cell is even bigger than the frontal sinus. Sometimes the frontal sinus is less pneumatized and this cell is, pneumatized bigger than the frontal sinus. See this, the frontal sinuses on both sides, supraorbital cell. Now, as long as the frontal sinuses are there, frontal sinus, you don't see the maxillary sinus because you are too anterior. You are too anterior. Now see the supraorbital cell started coming. You can see the pneumatization of the maxillary sinus or the maxillary bone has come. Now at the level in this coronal plane, if you see the maxillary sinus or the maxillary bone coming, that means that plane is far behind, too far behind to be a frontal sinus above. This cannot be frontal sinus so posteriorly. Number one, this is always supraorbital cell when you see the frontal sinus down below the level in the same plane, and that is the maxillary sinus below. And secondly, when you see this pneumatization with the cribriform plate in picture, this crista galli, it cannot be frontal sinus because the crista galli or the cribriform plate is always behind the plane of the frontal sinus. So this is another important finding. One can see whether it is a frontal sinus or the frontal recess. You can easily, differentiate into. Now, let me bring the soft tissue. This is to, identify the level of the anterioethmoidal artery. Let me show you. This is soft tissue window. Now I am reconstructing. For the reason I'll tell you. See, this is orbit. And you can change the window setting by your, software. I've changed the window setting again a little bit. Now see, I am coming far anteriorly here, going behind. See, this is cribriform plate. Now, the cribriform plate, where the cribriform plate is, forming the roof of the anterior ethmoid here. Along the roof of the anterior ethmoid, this is cribriform plate, the crista galli. As you go behind, the cribriform plate is disappearing. The anterior ethmoidal roof is going back. The same one, let me bring you for the easier, understanding. See this. This is the crista galli cribriform plate. Now, your roof of the anterior ethmoid, which is demarcated by the cribriform plate here, and the supraorbital cell here. Before going to the cribriform plate, regarding the supraorbital cell, the important information is, as you go behind, as the cribriform plate is, missing, and the post-ethmoid starts. See, this is a thick post-ethmoidal roof. Anterior was the thin anterior ethmoidal roof, that is cribriform plate, and before the cribriform disappears, what you get is coning of the orbit. See, the coning of the orbit, depending upon the depending upon the pneumatization of the anterior ethmoid, this coning of the orbit, what is that coning? This coning demarcates the, see the window setting I have changed. This coning demarcates the exit of the anterior ethmoidal artery from the orbit. This shows the exit of the anterior ethmoidal artery from the orbit. How can you make out? Why did I change the window setting? Look inside the orbit. Some better soft tissue detail. Look inside. I'm changing the window setting. This is your medial rectus muscle. This is your superior oblique muscle. And where the confluence of the muscle is, this beaking of the medial wall of the orbit starts. See this beaking starts here. This is medial rectus, this one, this is superior oblique, and this is where this anterior ethmoidal artery, this, leaves the orbit. This is a branch of anterior ethmoidal artery leaving the orbit from here, and from here, it runs towards the lateral lamella of the cribriform plate. It runs here into the roof of the anterior ethmoid bone, which is a thin bone, and high cellularity makes it even more thinner to make this artery more prominent. And this artery, sometimes the bone is too thin to make this artery running without any bone covering, and that is called artery running in the mesentery. So in that situation, this artery enters the lateral lamella of the cribriform plate and then enters the olfactory fossa, which is the intracranial structure. And then here it runs in the olfactory fossa anteriorly to come back in the entry part of the nose. That's how this artery has a course from different compartments, right from the orbit. First compartment is a branch of ophthalmic artery, which is a branch of internal carotid artery. So this carries the blood from the internal carotid system, then leaves the orbit, run in the roof of the anterioethmoid, that is second compartment, paranasal sinuses, where we are concerned with, which surgeons are concerned with, and then it runs to the lateral lamella into the olfactory fossa. And again, this is important because this part of the lateral lamella, where this artery perforates, is the thinnest part of the skull base. That's the thinnest part of the skull base. We have to be very, very careful to give any direct or indirect transmitted trauma to that region to give you a CSF leak. Because the bone there is very, very thin over the dura, and dura is tightly adherent to it and can easily lacerate with a thin fracture of the bone even. So you have to be very careful at that point of time. So this is all about the anterioethmoidal artery, how it leaves and runs through the orbital roof and enters the lateral lamella. Now, can you hear me, sir? Hello? 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 Am I audible? Hello?
Sir?
Hello?
Yes, sir.
Am I audible?
Yes, sir, you're audible, sir.
And the diaphragm is running?
Yes, sir.
Okay. So this was about how the anterioethmoidal artery you can look at. Now, while coming into the frontal recess, see this, as the frontal recess starts, the important thing as you go behind the frontal sinus, basically, your ethmoidal roof comes. There's the ethmoidal roof, the thin ethmoidal roof, and the cribriform plate in the midline. This is the cribriform plate, and see this continuation of the nasal septum above in the intracranial segment that is known as crista galli. This cribriform plate forms the floor of the olfactory fossa, and see the difference. The roof of the anterioethmoid is much higher than the floor of the olfactory fossa. Why it is so important? Because when you work in the anterioethmoidal roof, when you work here in the anterioethmoidal roof, here particularly in the frontal recess, very closely is the lateral lamella of the cribriform plate, which, as I mentioned, is one of the thinnest part of the skull base, the entire skull base. If you are not very attentive, not very careful, even a slightest medial movement at this point of time can hit the cribriform plate and get a CSF leak. So you have to be very, very careful at this point of time. In every patient, we need to see this thickness of the lateral lamella, the depth of the olfactory fossa, and all those things. And the surgical teaching points is, once you are working in the frontal recess, direct your instrument laterally. Every instrument should be directed laterally. The plane of the instrument should always be, keep the middle turbinate in view always. Always keep this middle turbinate in view and stay lateral to you, all lateral to the middle turbinate all the way. For that, you don't actually hit the medial lateral level of the cribriform plate, which is the medial structure over here. And that's a very important surgical catch point. And your radiology clearly explained this, how this turbinate is an important landmark to protect your lateral lamella while working in the frontal recess region. Secondly, the depth of the olfactory fossa is so important. The reason being, if the olfactory fossa is shallow, not very deep, your length of the lateral lamella you are in contact with is much lesser. The chances of damaging the lateral lamella and getting a CSF leak are minimal, relatively minimum, as compared to a deep olfactory fossa. Suppose this olfactory fossa is very deep till here, then the entire lateral lamella the length of the lateral lamella in relation to the surgical instrument is much, much longer and relatively much thinner as well. And the chances of breaching the skull base are much higher. So you have to be very careful. You have to calculate the risk as well all the time. This is very important for the beginner as well. As if you have such kind of difficult anatomy, you have to stay extra careful, explain your patient, keep your senior with you, whatever, to take extra precautions. So depth of the olfactory fossa, sometimes you get uneven cribriform plate, sometimes you get some other abnormal anatomy. You must have a close look at the CT scan to get all that information. Secondly, the important structure right from here coming into picture is the turbinate. You know, in the sinus surgery, the turbinates are very, very important structures. Not only anatomically, but for your orientation. These turbinate, particularly the middle turbinate, is all the way in your surgical, field, and this gives you a amazing landmark all the way to protect your skull base. As I mentioned here just now, stay lateral to the middle turbinate to keep your cribriform plate away. So we need to understand all three-dimensional anatomy of this turbinate. This middle turbinate, see there are inferior turbinate, which is relatively boggier, has some erectile tissue, as contributes to the allergic phenomena because of this erectile tissue, symptoms of the allergy, nasal blockage, and all that. Then this middle turbinate, which has three parts. Three parts means it is a single turbinate, but it has three parts in all three planes. For example, this first part running in the sagittal plane. See this sagittal plane, this part of the turbinate, middle turbinate, and going high up to the level of the cribriform plate at the junction of medial and lateral lamella. Can you see that? Medial and lateral lamella, this turbinate, the middle turbinate, particularly it's, the first part of the anterior-most part lying in the sagittal plane. And this is very important surgically. We must know this fact, how this upper part is inserted, the first part of the turbinate to the cribriform plate lateral lamella, and that's a catch point in surgery. The standard traditional teaching has been, because of this region, has been to avoid manipulation of the turbinate in the upper part close to the cribriform, otherwise can lead to a distant fracture at the level of the cribriform plate and you can get a CSF leak. So handle with care this part of the turbinate, particularly the upper part. And if you need to do something to it, you can use sharp instrument to resect it. Sometimes you need some sort of turbinoplasty for a floppy turbinate, for a concha bullosa pneumatized turbinate, or some thick hypertrophic turbinate to get extra space. And then you can use your sharp instrument through biting sharp scissors or whatever, to reduce the turbinate rather than pulling it. Any torsion of the turbinate at this point is hazardous and can lead to a CSF leak. That's why we must know how the turbinate is attached to the upper part of the skull base here, just particularly the anterior-most part lying in the sagittal plane. Now, as we go behind from here, see this turbinate. As we go behind, see, as the cribriform, until the cribriform is there, this is the first part. Until the cribriform is there, that is the anterior ethmoidal roof. Now, see now, how the roof is changing. This is the anterior ethmoidal roof and now it is the posterior ethmoidal roof, this one. And what happens? This turbinate takes a lateral turn. See, this turbinate is taking a lateral turn. Turbinate is taking a lateral turn to insert on the lamina papracia. See, on both sides, the turbinate is taking a lateral turn to insert on the lamina papracia, and that is the second part of the turbinate, that is known as ground lamella, that divides literally the cells which are anterior to it as an anterior ethmoidal group of cells, and the cells posterior behind are the group of cells are the posterior ethmoidal cells, and you can see this better in the you can change to the multiplanar view to see this middle turbinate in all planes. See this, what I am trying to show.
Sir, we
This
lost the
is-
screen share. Can you connect again, sir?
Okay, lost the screen share. Oh. Now,
Yes, sir.
now you got.
Yes, sir. We got that.
So what I am trying to show, this second part of the turbinate are inserted on the lamina papyracea, and you can see in the axial plane much better dividing all cells from anterior to posterior. That is what I am trying to show on the multiplanar view. What I'm supposed to do, some annotation request is coming again and again.
Decline, sir.
Decline. Okay. Now see, this is my middle turbinate which is turning. And see here, that is your middle turbinate. How you can see on the axial plane, I came to the right point, and this is the middle turbinate which is turning here. All cells behind are the post-ethmoidal cells, all cells anterior are the anterior ethmoidal group of cells. That is how you can differentiate the anterior from the post-ethmoidal cells easily. Got my point? So we must take the multiple planes in consideration to see all anatomical details in that particular region. So this is about the middle turbinate, first part, then the second part, and then as you go behind, this is the third part of the middle plate. The second part lying in the coronal plane. The first part lying in the sagittal plane. This is sagittal plane, the second in the coronal plane, and the third part as you go behind, see this, this happens to attach to the, perpendicular plate of the palatine bone forming the posterior wall of the medial wall of the maxilla. This is the perpendicular plate of the palatine bone, where this third part of the, turbinate is attached in the axial fashion all the way as you go behind. That's how the middle turbinate is attached to in all three parts, in all three planes. That's how we must look at the middle turbinate anatomy detail for the particular patient. So what we have seen so far, the frontal sinuses, the frontal recess, the cribriform plate, and the middle turbinate. This is Advacned, the biggest cell in the anterior ethmoid. See this Advacned, and see what you're looking at this region. This particular region is known as Osteometal Complex. Why this is key area? Why this Osteometal Complex is a key area? Why it is? The reason being, all the sinuses, the nasal sinuses, particularly see the frontal sinus drainage, see the maxillary sinus drainage. All these major sinuses drain through these narrow channels of the ethmoid, anterior ethmoid, and these channels are further narrowed. Why they are narrow? Because of this cellularity and bony structures. What the most prominent cell is? The bulla ethmoidalis. And this, what is this structure? This is uncinate process. This is middle turbinate, and this is the infundibulum through which the middle meatus or this the maxillary sinus draining into. This is the frontal sinus drainage pathway draining into this region, and all this confluence, this area is known as the middle meatal complex, where all major sinuses, most of the major sinuses are draining, and this is the major cause of the dependent sinusitis in these major sinuses. So in that situation, in order to, uh, deal with this sinusitis, this was the original concept from Messer Klinger, which was propagated by Professor Stamberger in late 70s, and brought in this concept of functional endoscopic sinusitis. The literal meaning of the functional was, you are not supposed to damage or deal with any kind of mucosa in the maxillary or the frontal, all these dependent sinuses, but to widen the drainage pathway of these dependent sinuses, the maxillary and the frontal sinuses. If you widen these the pathways, where the key area is the middle meatal complex, all these inflammatory changes in the dependent sinuses revert back on their own without dealing with the mucosa per se in the large sinuses. So to understand this, we need to be fully aware of the anatomy of the osteometal complex in this region. See this, what exactly this? Let me run in the dynamic way. Come from posterior to anterior. See this uncinate process. This is uncinate process. I'm coming from posterior to anterior, has a horizontal part. This is the horizontal part coming. I'm coming anteriorly now from here. This is the uncinate process as a horizontal part. Now it's a vertical ascent. See this, going back. This is the horizontal part of the uncinate. That's the vertical part ascending, ascending, ascending. See this, how the uncinate is going up. And creating these channels. This semilunar channel between the bulla and the uncinate is hiatus semilunaris. And this maxillary sinus drains through this infundibulum into the hiatus semilunaris. So this infundibulum is practically a three-dimensional structure, but this hiatus semilunaris between the bulla and the uncinate is a two-dimensional structure, and this drainage pathway is narrowed between these two structures. Any anatomical, abnormality of these two structures can lead to obstruction to the maxillary sinus drainage pathway and can lead to maxillary sinusitis. And edema of the mucosa in this narrow osteometal area is responsible for, obstruction of drainage pathway in this dependent sinuses. So now this uncinate, we must know how the upper part of the uncinate is inserted. That is very important from surgical point of view. We need to know where the upper part is inserting exactly. Fortunately, majority of the time, it is inserted high up laterally onto the lamina papyracea and giving this frontal sinus a medial drainage pathway. Let's see. See if I am going up. Look at the uncinate. Look at the uncinate. Look at the uncinate. See here. Here comes the Aganegi cell. The wall of the Aganegi. That's the wall of the Aganegi. Come back. See, this is the bulla behind. I am coming anteriorly. That's the wall of the Aganegi. This uncinate merges with the wall of the Aganegi, and give this frontal, see this frontal, medial drainage pathway. That's the medial drainage. See in one plane, the entire frontal drainage pathway in one plane. That remains medial to the uncinate, which joins the Aganegi to insert on the lateral wall. That is the commonest, the drainage pathway of the frontal sinus. That is the favorable one. You can go behind and fracture it out, all these things anteriorly to widen the drainage pathway. And you can happen to, use your any, instrument and come anteriorly. See, while using the instrument behind in the cell and coming anteriorly is a much safer, move than going behind with the tool with a jerk towards the skull base. So that is a much safer move. And with this kind of uncinate attached to the lateral wall, it is pretty safe. Now in uncommon situation, this uncinate. See the uncinate on this side as well, opposite side also. See how it is merging. Here it is merging with the this is Aganegi. This is Aganegi and insert on the lamina papyracea and giving this a see this frontal in one plane. See the entire medial drainage pathway of the frontal sinus. See, so beautifully you can see in dynamic CT scan. You can't make out all these things which I am telling you in your printed CT scan, that to limited scans without any dynamic three-dimensional information. So that information to me is as good as useless. Now see this uncinate and see this Aganegi, and that is the frontal drainage pathway. So in uncommon situation, this uncinate may go up and insert on the turbinate. If it happens to get inserted on the turbinate, as I said, the upper part of the turbinate is close to the cribiform plate. It inserts on the cribiform plate. So if this uncinate goes up and inserted on the cribiform plate and you try to fracture it out anteriorly, it can give a fracture at the turbinate as well, which can be transmitted to the skull base and can get a CSF leak. So that is very, very unfortunate. If you happens to fail to notice this, the upper part of the insertion of the uncinate, whether to the turbinate or even to the skull base, in that situation, you are never supposed to, break the uncinate by any tool. Rather, punch it out with a through biting or some other sharp instrument rather than fracturing it by any curate or ball probe or any other thing. So that is an important thing. And again, as I said, this talk is on the surgical perspective. This anatomy has to be correlated on the surgical ground, that how every anatomical detail is so important in carrying out a safe sinus surgery. See, sinus surgery is not about removing all these structures, it's all about carrying out a complete, establishing the drainage path of all sinuses, preserving the mucosa. That's why it is called functional, because the function is going to be served by the mucosa, and preventing complication as the safety margin is very less, as the critical structures, the orbit and the skull base is very closely related from anterior to posterior, all around from superior, laterally, everywhere, and a sub-millimetric, a wrong move can lead to a disaster. So you have to be very, very careful with a sub-millimetric three-dimensional dynamic CT scan to carry out a complete functional and safe sinus surgery. So this was about the uncinate, that is about the bulla, that is about the frontal recess. Now as we go behind and see every point, you can see this is again to be noticed and very important medical legally as well, too important to inform the patient as well about the kind of the turbinates you have, the kind of nasal septum you have, because the sinus surgery many of the times, or in majority of the cases, require some sort of turbinate and septal correction as well. If you need a septal correction, you need to pack some time the nose for 2 days, whatever. And you need to carry out a proper septoplasty. If you need to do some sort of turbinoplasty for a concha or some paradoxical whatever turbinate, and we are supposed to inform the patient as well. So any kind of septum or turbinate surgery required, majority of the time you can ascertain by the means of the CT scan, and then you can inform your patient, beforehand, rather than giving a surprise to the patient later on, because many of the patients Google a lot and they know what exactly is required to be, done in our patient. Why does the plan of change? What the other, the patients have a habit of, throwing questions like this, and so you have to be very careful in this era by knowing each and every your plan on the record beforehand, and that's how the surgical detail, the CT scan details is very important in that relation as well. Now, as we go behind now look at the change. This was anterior. You see the maxillary sinus. This was the infundibulum. Now going behind. Now I am going behind. That is the ground lamella now. Now this is the ground lamella. Now what is coming? What is the change? The dramatic change as you go behind. This is your orbit. The orbit is reducing its size. See anteriorly, see posteriorly. As you go behind, the shape of the maxillary sinus is changing now from a globular shape to a more and more oval shape. Now it is becoming as you go behind, and see behind this ground lamella, now the cells appearing are much less in number and larger. See this, such a big cell. And fourthly, the roof of the skull base is changing. This is anterior ethmoidal roof, so thin one. And now as you go behind, the roof of the anterior ethmoid is becoming more and more flatter and much thicker as compared to the anterior ethmoidal roof, where we are always scared with dealing with the turbinates. Now, as we go behind, this is the posterior ethmoidal roof, and the turbinates which are attached onto the posterior ethmoidal roof. See the turbinates again. These are superior turbinates. So this is a posterior ethmoidal cell, and relatively narrow space. This is the nasal septum. This is the superior turbinate, and this is the orbit. So posterior ethmoidal cell again is like a box. You can see medially, or my friend here, Dr. Ashish Bhumkar, he always mentions it's like a box. The frontal sinus is like a box between bony walls, and if we assume a three-dimensional in our head, and what exactly the box boundaries are, or our situation becomes, the understanding becomes much easier. So here again, it is like a box. There is the superior turbinate making the medial wall. There is the orbit making the lateral wall of the posterior ethmoid. The thick posterior ethmoidal roof, that is very, very important, and this turbinate is attached to the posterior ethmoidal roof. Relatively a thick roof, and you can deal with the turbinate in a much better way than dealing with a dicey middle turbinate attachment. And every surgical move, see, this is so important to deal with every structure. You can refer to Dr. Standard teaching from Dr. Dharamveer Sethi, who has practically revolutionized this surgery in our country through his hundreds of workshop almost 2 decades before now, you can say. And I've been fortunate to have attended his course, his private teachings even in Singapore, and that has made the things much, much better now. So this kind of teaching, dealing with each and every structure, so minute a structure, some millimeter structure in a fashion that going from anterior to posterior in three-dimensional way is important in carrying out a safe sinus surgery. So now, as we go behind, now the things are changing now. See now, your septum is there. This is your postethmoid. This is a postethmoidal roof. So you can carry out this posterior, ethmoidal sinus surgery now with with these box boundaries in your view. Above the skull base, medially, superior turbinate. As long as you stay medial to the superior turbinate, lateral to the superior turbinate, you are in the right cavity, and medially, your the postethmoidal part of the orbit is there in the lateral relation. And here you have to be careful. Anteriorly, there is a lot of pad of fat between the intraorbital structures and the sinuses. Even if you breach the bone, the fat prolapses and protects the important structures, the muscles and other intraorbital structures. But as you go behind, there is relatively no fat. You have to stay extra careful. The bone is much thinner. If you happen to breach the bone, you can easily go and damage the medial rectus muscle over here. Inferior rectus over here, medial rectus over here. And this is very important to keep in mind while working in the postethmoidal cavity to stay safe, to stay medially, more and more medially, and laterally the critical. While working in the frontal sinus, you're advised to stay more laterally in the frontal recess to avoid damage to the skull base. Here, while working in this region, you are advised to stay more medially close to the superior turbinate to prevent damage to the posterior part of the orbit. So everything is important. Now, as you go behind, what is important? Behind the postethmoid is supposed to be the sphenoid sinus. And it is relatively not, it is not in a linear fashion that you're supposed to see the sphenoid sinus behind the postethmoid sinus. So the sphenoid sinus is a more centrally located structure as compared to the laterally located bilateral ethmoids, and overall it depends upon the pneumatization of that particular patient. Now, to safely approach the sphenoid sinus, we always mention in our live surgical demos, always approach the sphenoid sinus medially. See this, along the nasal septum. Now see the changes. We must know at this point of time, because this is a crucial part of the sinus surgery when we are carrying out the surgical part, transition from the postethmoid to the sphenoid sinus is crucial. And that identification of transition from the postethmoid to the sphenoid sinus is much crucial from complication avoidance point of view, because majority of the dreaded complication of sinus surgery happen to occur while you operate inside the sphenoid sinus, because of the close proximity to the carotid artery, optic nerve, skull base, sella, so many important structures. So if you happen to go into the sphenoid sinus without orientation, accidentally one can easily avoid those injure those structures, and that is a disaster, I would say. So entry to the sphenoid sinus should be in a proper way, in a fashion that you must know where exactly you are working. So in transition to the sphenoid sinus, there are a lot of things you can make out surgically. There are surgical landmarks which you need to consider while operating, and there are certain radiological landmarks you must know while looking at the CT scan. Now, radiological landmark number one, look at the roof of the ethmoid so far and the roof of the orbit. All along from lateral to medial is the frontal bone. Roof of the frontal sinus, roof of the ethmoid, and roof of the orbit is all formed by frontal bone. And behind is the sphenoid bone, which has its own sphenoid bone roof. And we must know this transition radiologically as well. This is number one. See this. See, now the roof is intact right from pterion to pterion, you can see. Now, this is post-sigmoid. Now, if I happen to enter into the sphenoid, what has happened to the roof? See now, this is the sphenoid wing. This is the sphenoid roof. The frontal bone has disappeared as you go behind. And once the frontal bone has disappeared, that means the sinus below is the sphenoid sinus. So simple radiologically one can get to know. Number one. Number two, the orbital apex. Look at this, the previous picture. This is the inferior orbital fissure. Now, as I go behind, see what is happening? That's the sphenopalatine foramen coming. That's the orbital apex coming. That's the inferior orbital fissure, sphenopalatine foramen here. Once you see this foramen, this is your sphenoid sinus. It cannot be anything. That is too posterior for any other sinus to be. Number two. Number two, look at the nasal septum. This nasal septum running from top to bottom, running from the roof to the floor of the nasal cavity, all the way during from anterior to posterior. And as you approach the sphenoid, see what happens. As you approach the sphenoid, there starts the broadening of the nasal septum, and that forms the sphenoid. See this? That's caused the sphenoid crest. That makes the sphenoid rostrum, and that rostrum forms the floor of the sphenoid sinus. So again, now the septum earlier was from top to bottom. As you approach the sphenoid, the septum limits from the floor of the sphenoid to the bottom, and that is the level of the rostrum of the sphenoid, marking the entry of the sphenoid sinus. And as you go behind, the sphenoid is lost, and then the choana comes. The septum is lost and the choana comes. So we must know where the rostrum is. That's the beginning of the sphenoid sinus. Now, another important thing for the sphenoid sinus ostium, to deal with the sphenoid sinus ostium, this is a standard teaching in our practice to emphasize medial entry to the sphenoid sinus. See this? That's the post-sigmoidal cell. That's the superior turbinate. That's the level of the superior turbinate. We always advocate, stay medial to the superior turbinate as you go behind. Stay close to the septum, and between this, that is the level of the ostium, the sphenoid sinus. See the rostrum here, and that is the level of the sphenoid ostium on both sides. So go flush with the sphenoid, flush with the septum at the level of the floor of the orbit, the roof of the maxilla or floor of the orbit here. See, at this level, flush with the septum, not laterally. Flush with the septum. This is most important. Below this level, not above this level. Above this level, you can go into the skull base anteriorly. And if you enter into this, that is the sphenoid sinus entry. And now you are in the sphenoid sinus. Sphenoid is, very important to understand anatomically. For the skull-based surgeons now, because the endoscopic skull-based surgeon has established itself for many of the pathologies, not only for the paranasal sinus pathology, for the not only the skull-based pathology, but many of the intracranial lesions are now, this endoscopic approach has become a standard of care now because of its distinct advantages. And for that, the sphenoid sinus is the center of universe. For endoscopic skull-based surgery, the sphenoid sinus is the center of the universe. And lot many intracranial structures, important intracranial structures, are traversing through the sphenoid or around the sphenoid, and we must know each and every structure here in a three-dimensional fashion. I would say here that's the most important area for a surgeon to execute his work in a very, very careful manner. The reason being, the critical structures are in close proximity now. As compared to the anterior one, the complications are more hazardous, more fatal, and you have to stay extra careful for that reason here. So in the sphenoid sinus, this is the intersinus septum. Now, as I said, this is the roof of the sphenoid, formed by the lesser wing of sphenoid. This is lesser wing of sphenoid, and this is the greater wing of sphenoid. That's the lesser wing of the sphenoid. And in between them is the superior orbital fissure, and See this, there's the clinoid processes and this pneumatization of the clinoid process forming the, and what you see endoscopically, this is the opticocarotid recesses. That's the opticocarotid recess. That's the optic nerve making the mark over here, the indentation of the optic nerve here. Here the optic nerve runs into the orbit here like this. If I come anterior, this is orbit. And that's the optic nerve going behind here and forming the optic chiasma here in the roof here. So that's the optic nerve coming here and optic nerve coming this side. See this? This is the optic nerve. So this is the opticocarotid recess, and here as you go behind, that's the impression of the, as I would say, as I go behind, that's the impression of the carotid artery here below. So above is the optic nerve, below is the carotid artery, and see this pneumatization is known as opticocarotid recess, lateral opticocarotid recess. Endoscopically, you need to mark all those areas, the medial OCR, lateral OCR, to mark your anatomy perfectly. And this is very important to understand what you can make out with a CT scan here. The optic nerve is fully covered with the bone. Many a times it is dehiscent. You have to be very, very careful while using any instrument inside the sphenoid sinus, particularly sharp instruments when you are using. And this is the carotid artery again covered with the bone. In certain percentage of the cases, you get the carotid artery dehiscent here, and you have to be very, very careful and knowing this detail beforehand, before starting the surgery, particularly in the large expansile, sphenoid sinus, particularly expansile lesion like fungal lesion, allergic fungal sinusitis, where the fungal mass is expanding and giving, bony erosions, expansile bony erosion, making all these structures dehiscent. We have seen many cases where the bilateral carotid dehiscent, bilateral optic nerve dehiscent, and the entire dura in this region dehiscent because of the expansile erosion, because of the fungal and other mucocele and other regions. So in those cases, you have to be very, very careful, because that is not invasive disease. It is expansile disease which happens to erode the sinus walls all around. And since the sphenoid sinus has more critical structures around, you have to stay more careful. Now, in this region, so this was the carotid artery prominence, that was the optic nerve prominence. You have to stay careful as you go behind. At this point, this is more important from the skull base point of view as compared to a regular sinus surgery point of view. This is the greater wing of the sphenoid, now on both sides, and the greater wing is perforated by various neurovascular bundles to pass from intra to extracranial structures. So there are certain important areas we must know. From sphenoid has many parts. This is the sphenoid body. You have seen the lesser wing anteriorly here, the greater wing here, and the two pterygoid processes emerging from the junction of the body and the greater wing inferiorly, ending separately as separate plates, the medial and the lateral pterygoid plates, enclosing the pterygoid fossa in it, and that's the pterygoid body per se, I would say. And through this region, see this two nerves, foramens traversing the medial wall, being the Vedian canal, the Vedian nerve. See this. This is the pterygopalatine fossa here, the Vedian nerve traversing the pterygopalatine fossa. It is coming from behind. See this Vedian nerve, if I follow, Vedian nerve comes from here, forming in the pterygoid canal where the carotid artery is coming, and the greater petrosal nerve forming with the deep petrosal nerve, the Vedian nerve, and then it passes anteriorly into the, see this how I am coming anteriorly into the pterygopalatine fossa. So that is the Vedian nerve, and this is a very, very important landmark for the skull base surgeons, particularly for the foramen lacerum carotid artery. Carotid artery traverses the skull base through various parts, and one of the most important part for the foramen lacerum region, every part has a different anatomical landmark which is more relevant, and for the foramen lacerum carotid artery, the most relevant landmark, I would say, besides the Eustachian tube, is the Vedian nerve. Follow the Vedian nerve, easily you can get into the pterygopalatine fossa and follow it, and behind where it crosses the carotid, turn at the level of the foramen lacerum to go up and laterally, and that is how you can save the carotid artery from injury by means of following the median nerve as one of the important landmarks. Laterally here, another foramen traversing, through this bone is the V2, the foramen rotundum, through which the second part of the, trigeminal nerve is coming out of the cranium. There are three parts of the trigeminal nerve, the V3 far behind V2 here and the V1 passing through the supraorbital fissure above. So V3 there laterally, I can show this laterally. This is V3, that is the foramen ovale. More posteriorly, see it emerges like these fingers, separating from each other and going away from each other. And so the first part, the first division, this is the third division, most far behind. Then the second division, this V2, and the first division passing through this supraorbital fissure. That forms the inferior most part of the supraorbital fissure. So the V2 is separated from the supraorbital fissure. It is inferior to the supraorbital fissure. Here is the supraorbital fissure, and this is separated by a bone, that is the maxillary strut, and this is V2, and V2 and median nerve, the median canal form two important landmarks in this region. If this pterygoid bone happens to get pneumatized by the ongoing pneumatization of the sphenoid sinus, the sphenoid is normally centrally pneumatized, but in more extensively pneumatized sphenoid sinuses, this pneumatization extends into the surrounding bones, and if this pneumatization involves or pneumatizes the pterygoid bone, then it is known as the lateral recess of the sphenoid sinus. And this is very, very important because this becomes forms one of the very common site of a CSF leak, wherein this lateral recess, is roofed by this temporal lobe of the brain, and this thin bone, particularly in situation of the high intracranial pressure, can easily break to give a CSF leak. So in that situation, this pterygoid, this bone is pneumatized, hollow, and forming the lateral recess over here. And the standard approach nowadays is to go endoscopically transpterygoid. Transpterygoid means drill away the anterior wall of the pterygoid to get head on to the the site of the leak, and then you repair like any other leak wherever you get. So there is no difference in that. It's the approach which matters, and for this kind of leaks, it is the transpterygoid dissection or the transpterygoid approach which is more important, and that becomes the standard straightforward approach to deal with such leaks. So this is about the pterygoid bones, the sphenoid bone, and the V3 I have already shown, and this is the greater wing of the sphenoid, bilateral V3, the foramen ovale here, and all this. This is about the anatomy of the paranasal sinuses. One can or one should read while getting onto a CT scan of the paranasal sinus for sinus surgery or your skull base surgery patient, to give you a complete information about the particular area you are operating upon. There are certain informations which are gained best in the sagittal plane. For example, the coronal gives you maximum information, that too easier to understand as you get in the same plane, and the other planes are important for certain reasons. I'll show you quickly. There's the sagittal plane. Sagittal plane gives you more information for the frontal sinus. Number one, that's the most important plane, most important thing to which plane which gives you maximum details of the frontal recess anatomy, which you require surgically regarding the orientation of the cells which are attached to the various walls of the frontal sinus, the drainage pathway of the frontal sinus, and all that. The relationship of the sella and the sphenoid sinus is best ascertained on the sagittal plane. Sometimes there's a, as I said, the sphenoid sinus is the center of universe for the skull-based surgeons, and the reason is the advantage because of this afforded by the sphenoid sinus, which is pneumatized, which gives you direct access to the skull base. Many a times, the sphenoid sinus is not pneumatized, a conchal kind of the sphenoid sinus that offers you a big challenge to deal with the skull-based pathology, as you have to go through the thick bone, drill through the thick bone, the bone which ultimately covers the carotid and the the optic nerve, to stay extra careful, and that conchal kind of pneumatization is one of the relative contraindication for endoscopic skull-based surgery procedure. So kind of pneumatization, kind of relationship with the sella. If you have an onodi cell, this gives you another good thing. Then the relationship of all the lamella in the lateral wall one by one each other, you can establish best on the sagittal plane. The slope of the skull base. See, the skull base is not flat; it is slopy, and this slope is different in different patients, and this is best ascertained on the sagittal plane. Similarly, there are certain structures which are best depicted on the axial plane. See this axial plane. Like for example, deviation of the nasal septum right from anterior to posterior plane, you can ascertain best on the axial plane. Relationship of the anatomy of the osteometal complex is best ascertained on sagittal plane. See the drainage pathway of the maxillary sinus, drainage pathway, how it passes through that's the uncinate bone, and everything best ascertained on the axial plane. Then the Onodi cell you can see best on the axial plane if it is. Let me show you. This patient doesn't have. Otherwise, see this is frontal sinus. What happens in Onodi? Let me show you. Had there been Onodi, what would happen? This optic nerve coming from the orbit running in the lateral wall of the sphenoid sinus. Normally, this is normal situation. Now, what happens? Suppose this cell happens to have overgrown above and beyond the sphenoid sinus. This postsigmoidal cell overgrows behind. This optic now happens to line the lateral wall of that postsigmoidal cell that is known as Onodi cell. So this kind of anatomy understanding and knowing this information is very vital. Otherwise, if you keep going behind from the postsigmoid can easily hit the optic nerve, and that would be a disaster, I would say. So stay medially, go to the CT scan, find if there is any Onodi cell. Even in the coronal section, you can find a certain Onodi situation. See this, Onodi is what? See from postsigmoid, if I go from postsigmoid to sphenoid, see, had there been Onodi, one of the postsigmoidal cell would have overgrown beyond the sphenoid sinus and would have been there above the sphenoid sinus, would have horizontal septa into it, and the above cell would be Onodi. So you can ascertain that Onodi situation in the axial plane, also in the sagittal plane, in the coronal plane, all planes you can ascertain. So this understanding is very important. Then the frontal sinus drainage pathway, you can, the supraorbital cell, you can get a better information. See this frontal sinus drainage pathway, whether it is medial or lateral. See this is the medial drainage pathway of both frontal sinus. You can easily make out. That's the medial drainage pathway of the frontal sinus. The easiest way to make out, that's the frontal sinus, that's the medial drainage pathway. So easy that no other plane can give you that. See the frontal sinus, and that's the medial drainage pathway. No other plane can give you this vital information as simple as the axial plane gives you. So all that information is given best on the axial planes. Then the information about the nasopharynx, eustachian tube, all these, the pterygoids, see this, that is particularly when you deal with the tumors like JNAs and all, the axial plane info gives more information. This is the pterygopalatine fossa, relatively a collapsed fossa, that's a pterygomaxillary fissure, that's the infratemporal fossa on both sides, that's the eustachian tube torus. See the torus of the eustachian tube, and that is the eustachian tube opening. This is collapse here, that's the eustachian tube opening, and then behind is the fossa of Rosenmuller. Behind that is the fossa of Rosenmuller. That's the nasopharyngeal, lymphoid tissue. So, lot many informations are best assigned in the axial plane. All intraorbital details are best ascertained on the axial plane. So all, muscular and other details, the optic nerve, the white, they see this recti muscles are best ascertained on the axial plane. See this, what I was telling, this is the fat pad which is there interposed between the sinuses and the medial rectus anteriorly, which is conspicuously absent behind, in the postsigmoids. So that is how you can make out, the fine details of certain areas on the axial planes better as compared to the coronal planes. But by and large, we must see the CT scan in all three planes simultaneously. Now, this is one investigation used for the, inflammatory disease of the paranasal sinuses to deal with, that is chronic sinusitis, and for that CT scan is more important. For other pathologies, for tumors, other skull-based pathologies, CSF leaks, or to get any other soft tissue details, MRI is the investigation of choice. MRI has the inherent, versatility of giving you variety of sequences, hundreds of sequences one can get from MRI, which every sequence will give us different details for tumors, benign, malignant. To differentiate from benign to malignant tumor, MRI is so important by means of the diffusion and the contrast imaging that one can almost, uh, you know, up to more than 98% sensitivity, you can say that whether it is benign or malignant on the basis of the MRI. So I'm not going into because of the time constraint, I'm not going into the MRI details over here. We'll take another session for that, surely, whenever possible, to go beyond in the radiology, beyond the paranasal sinuses, beyond the inflammatory disease of the paranasal sinuses. And for that reason, the role of the CT scan is less and less now. The role of the CT scan is most important for the chronic sinusitis, where we need bony details of the paranasal sinus labyrinth, you can say. But rest of the things for other pathologies, for any other thing, maybe tumors or anything, the MRI is the investigation of choice. For various reasons, we always discuss that, and whenever the time permits, next we will give you details of the what is the importance of the MRI in the paranasal sinus pathologies. That is very, very important to understand. Again, the onus is on the surgeon to order MRI. When to order MRI, when to order CT scan is very, very important for getting optimal information for the diagnosis. For example, the patient has a tumor, and if you're ordering a CT scan, PNS is of hardly any use. Particularly plain CT will have hardly any information for you. Even if a contrast CT will not differentiate into soft tissue. The MRI, by means of its different, sequences, by means of contrast, T1, T2, diffusion, so many other sequences, you can characterize the soft tissue much better than what kind of pathology it could be. Whether it is a fluid, whether it is a hyperintense mucosa, whether it is a necrose tissue, whether it is a benign tumor, whether it is a vascular tumor, whether it is a malignant tumor, whether there is a high intracranial pressure, so many things, and number of things you can, get from the MRI. Every tumor has a different, pattern you see on the MRI. Even on the basis of the, just on the basis of the MRI, you can reach to the diagnosis to a, some sort of certainty, I would say, for many of the pathologies like inverted papilloma and other things. I am not going to the details because of the time constraints today. So, but definitely we'll take on next time to get you full MRI details. And believe me, MRI is one of the most important investigation, and the onus is again on the surgeon to order all those sequences. Suppose you write up MRI brain, MRI PNS, MRI, every sequence is acquired separately in different planes differently. So it's a time consuming investigation. If you write a MRI PNS, the diagnostic center may do 1 or 2 sequences and finish MRI in 10 minutes, which sometimes can be as good as useless. So the onus is on the surgeon to acquire complete information. You need to write yourself that what kind of MRI you want: T1 multiplanar, T2 multiplanar, FET suppressed multiplanar, you want contrast, you want a diffusion, you want ADC, you want flare image, you want, angiogram. You have so many things. You have to order yourself specifically in your, prescription, so that the radiologist can do a complete job and give you complete information. Otherwise, in spite of getting MRI done, you are left with a little bit of information, making MRI useless. So that is important, and the time is to understand this fact to get maximum information, because it is your understanding of the radiology in a proper way can help you carry out your, surgical planning and surgical education in a best way, I think, and that we have been experiencing in our practice as well. The MRI is proven to be one of the best investigations for the skull-based pathology, for the tumors and other things. So we'll take it in a different session. And meantime, we have probably 5-10 minutes. Hello?
Sir,
Yes,
Sandeep
Sandeep,
here.
we can take questions. Yeah, we can take questions. We have 5-10 minutes left. So
Yes, sir. Yes,
if you
sir.
have any questions, we can surely take.
I will ask the organizer, sir. Thank you, sir. It was an amazing lecture, sir. As usual.
Nothing new for you, Sandeep. Sandeep has been with us. He's worked with us for a long time, and we have been had been working as a unit together. And he's amazing guy. I really
Always
even
honor.
learned a lot from Sandeep sometimes. You know, he's so committed.
Good, sir. Thank you, sir. Thank you so much. Thank you so much to accept the invitation and coming, sir. We're all very happy. After a long time, we are listening a lecture from you, sir.
Thank you so much, sir.
Thank you, Sanjay.
Excellent presentation. Very detailed from basics to the top level, sir. Everything you covered, everything, sir. It was like a
We'll
superb.
take MRI in a separate session sometime.
Yeah, sure, sir.
Pleasure. Thank you so much, sir.
Thank you, sir. Sir, some of the questions in the group. Sir, Dr. Sriharsha, can you read
Sir,
out
yeah.
important questions?
I'm here, sir. So we have enabled unmute option, sir. So
Yes.
any of the participants, if you want to interact, we have five more minutes. You can unmute and directly discuss with Jain, sir.
Yeah,
Hello,
sure.
sir. Good evening.
Good evening.
Thank you for the lucid presentation, sir. I wanted to ask you that do you prepare the patient before ordering a CT scan by either prescribing them systemic or topical medication as a routine, or do you order a CT scan at the outset?
See, the best timing for the CT, your question is valid. The timing of CT scan is very important. As I said you earlier, CT scan is not commonly ordered for the diagnosis. CT scan is ordered to get anatomical details to facilitate your surgical planning. So the anatomy doesn't change. Your pathology may change. Your sinusitis, the level of sinusitis, the grading of the sinusitis may change. So the investigation is to be ordered at the right time when you plan surgery rather than a diagnosis point of view. So it should be done before surgical planning.
Okay, thank you, sir.
Yeah, queries?
Hello?
Sir.
Hello?
Sir, Jain, sir.
Yes, sir.
Sir. I'm asking the audience, ask any question.
Sir, I'm Dr. Kavita from Jabalpur. I'm asking, sir, what are the various other indications like CT with contrast, or what are the particular contrast sequence which we order in special sequence of CTs? Like this was the basic.
Yes, madam. Your point is valid. See, for the CT scan, as I mentioned, the use of CT scan in the paranasal sinuses is limited to give you bony details. And the plain CT scan is adequate for giving you all bony details for a sinus surgery. Except sinus surgery, if you are getting a CT scan done, it should be contrast like for the tumors and all. But for that, MRI is the investigation option. Sometimes you get both MRI and CT scan, wherein the MRI gives you soft tissue details and CT in bony details. And you can club together with a fusion system in your navigation as well. So the CT is reserved for bony details and MRI for soft tissue, and the role of contrast CT scan is now becoming less and less in practice. When it comes to contrast, that means you are dealing with a tumor, and then a contrast MRI is more useful than a contrast CT scan. So by and large, a plain CT is good enough to give you bony details, because the role of CT is limited to give you bony details. That's it. And in sinus surgery, you need only bony details. In tumors, you need more other details. For that, a contrast is required for the MRI rather than a CT scan, and that is a much better, proposition, I would say.
Thank you, sir. Sir, I have always been a bit confused about the greater wing of sphenoid when we are doing for this mucus. So anything more we can see in CT of greater wing of sphenoid?
Yes. See, the sphenoid bone, as I showed, has various parts. Has a body, has two wings, the greater and lesser wings, and the pterygoid processes. Greater wing forms the floor of the middle cranial fossa by and large. and extends far laterally, both sides, forming the floor of the middle canal fossa. And all those major foramina through which the neurovascular structures travel from intra to extracranial structure are passing through the greater wing. So greater wing is a thick bone forming the floor of the middle canal fossa. That bone is involved in many, pathologies, maybe tumors and the inflammatory pathologies. And we have seen recently in the mucor crisis, the greater wing of the sphenoid is one of the common bones wherein the fungus, traverse the bone and involve the bone, necrose and so many other things. So the greater wing and understanding of the anatomy of the sphenoid is very important, not only the greater wing.
Thank you, sir.
Sir, very good evening, sir.
Good evening, sir.
This is Dr. Sambasirav from Telangana, Warangal.
Yes, sir.
Sir, very excellent lecture, sir, and very crystal clear, sir, all findings and all these things. Only thing is, in this COVID era, sir, are there any specific changes in CTPNS in mucormycosis compared to routine PNS? Because so many cases we are seeing, sir. Any specific findings did you find, sir?
Yes. So CT scan, as I mentioned, gives you bony details.
Sir.
Now, as far as the mucormycosis is concerned, the CT scan has a limited role because mucormycosis gives bony infections. It replaces the bone marrow, involves the bone, gives bony necrosis, and all those things are best appreciated on various MRI sequences wherein the marrow is replaced by the disease. So signal intensity changes and the bone marrow is best picked up on MRI. So by and large, for mucormycosis particularly you are talking about, our investigation of choice is MRI, and CT has a very limited role. Sometimes the normal, signal intensity changes in the bone may be picked up as a mucormycosis wrongly. So in a mucormycosis, solely our investigation of choice is MRI with some particular sequences, and it gives amazing details of the involvement of the different parts of the bone in mucormycosis. We can take in a next MRI talk sometimes and cover the mucormycosis completely.
Really, it's MRI we can write in mucormycosis regularly, sir?
Yes, that's the only thing which gives you, complete details about the extension of the disease, because the inflammation gives certain signal intensities in different, sequences, particularly the fat suppressed sequences, and the contrast together, you can pick up complete extent of mucormycosis, which CT scan cannot give. Because in mucormycosis, it is not the bony details you want. You want more and more soft tissue details along with.
Yes, sir. Yes, sir. Thank you so much, sir. I really congratulate Dr. Sudeep and also our Ramesh for getting such a great speaker for all of us. Entire India and almost globally they are watching today for the past 2 hours. We are really glad your talk, sir.
Sir, good evening, sir.
We'll be seeing sir in action in Karimnagar.
I am former director of Health Telangana State, sir.
So nice to see you, sir.
Thank you, sir. We met you so many times in conferences and workshops, and we are looking forward you at Karimnagar.
Sure. Surely, I have already promised Dr. Naidu. I have been to Karimnagar earlier with him. It was a pleasure being there.
Sir, thank you, sir.
We assisted you. I assisted you in the conference in Karimnagar, sir. 2016.
Advacned, sir. Sir wants to talk. Advacned Reddy, sir.
No, sir.
సార్ ఇంతకుముందు మాట్లాడడానికి వచ్చారు.
ఓకే.
Advacned సార్ and Sriharsha Reddy sir, Sathish sir.
Yeah.
Anybody wants to share?
Yes. Really, we enjoyed the talk.
Yes, sir.
Without
it will continue, sir. It will continue regularly.
Even while going to washroom also, we could catch our cell phone. That was interest. Yeah. Thank you.
Hello.
Yes, sir.
Hello, sir.
Yeah.
Hello.
Good evening, sir.
Good
It's
evening.
very good presentation, sir. Very excellent demonstration of the things, sir. And my question is, please show the frontal recess drainage pathway once again, sir. You have shown already in axial
Yes.
cuts.
Axial cuts.
Just
Okay.
in axial cuts, sir. You have shown the medial drainage pathway.
Yes.
I want to see that one again.
They have stopped sharing. How do I share now? I think they have. Yes. Yes. So, say this.
Yeah.
You
Yes,
wanted
sir.
to say the axial. Are you getting the axial planes?
Yes, sir. We are getting the axial plane. The frontal recess. Yeah.
See, this is frontal sinus from above.
Yeah.
I am going down where the drainage is
Yes.
going to be.
Yes.
And see, this is the intersinus septum. This is the frontal
Yes.
sinus.
Yes, sir.
And that is the drainage pathway. That is the medial drainage pathway. That is the Agarnese cell. See, that is
Yes.
the Agarnese cell.
Yes,
And
yes.
that is the drainage pathway. And this is going here. See this.
Yes, sir. Yes, sir.
That's the medial drainage pathway.
Okay.
Now, you can see better if you want to understand it better. I
Yes.
can take the help of 3D.
Yeah.
See this.
3D.
I will mark out
Yes.
this pathway on this. Now see.
Yes, sir.
Now see in all planes. See in
Yeah.
the sagittal, this is your drainage pathway. See this.
Yes. Yes.
Now, see this. This is your
Sir.
drainage pathway. Can you see the drainage pathway?
Yes, sir. I can see.
Now, if I put here, you
Yes.
can see in the sagittal plane the drainage pathway.
Yeah.
See this?
Yes.
See the drainage pathway?
Yes. Very nicely seen, sir.
And same thing
In the
here
axial.
is the axial plane, the same point. See, this is the drainage pathway.
Yeah.
That's the drainage pathway. So this drainage pathway, why the axial plane is more preferred?
Yes.
Because the sinus is above and drains inferiorly. See this.
Okay.
I am coming from above. See this. I am coming from above, coming from above.
Yes.
And
Yes.
as
Yes.
the drainage comes, it starts narrowing. And see, this is the complete pathway.
Okay, sir. Okay, sir.
So the best way to see the drainage pathway is the axial plane actually.
Okay. Okay, sir.
Now see the complete drainage pathway there.
Yes. Very
It
nicely
gives you a good mediolateral information about the size of the Agarnese or size of any frontal cell
Yeah.
responsible for blockage of the drainage pathway.
Okay, sir. Okay, sir.
Bottom line is, your radiologist can't give all this in your report.
Really? Yes.
That you have to see dynamically yourself. So it is not the fault of the radiologist, I would say. It is a need of the time for the surgeon to understand themselves to relate in surgical planning.
Yes, sir.
In surgical execution, this is I would say like a Google map,
Yeah.
wherein you can use all these detailed, fine details, dynamic information to translate into surgical, execution.
Yes, sir. Yes, sir. Okay, sir. Thank you, sir. And my another doubt is that please show the superior orbital fissure, sir. Please trace the superior orbital fissure.
Okay. Superorbital fissure. See
Yes,
what
you have
happens.
shown already.
Yes. I'll tell you where the superorbital fissure is. See, anterior to posterior. Superorbital fissure, let me tell you first before I show there to orient you. Superior orbital fissure is actually the anterior continuation of the cavernous sinus.
Cavernous sinus, yes.
So cavernous sinus through which the carotid artery runs.
Yes.
And anterior to that space continues where all the nerves coming from behind, passing through the cavernous sinus, run anteriorly into the orbit.
Yes, sir.
That's my point, into the orbital effects.
Yes,
so that area through which the cavernous sinus continues anteriorly into the orbit is the superior orbital fissure.
Yes.
And superior orbital fissure is an inferior anatomy. Now, let me tell you on CT scan 3-dimensionally.
Okay.
See, this is axial. Let me make it 3D.
Okay.
Now, if I am coming anteriorly, see, this is your cavernous sinus. This area and the sphenoid sinus, see this. Above is the optic nerve. See, this is the optic nerve coming.
Yeah.
Above is the optic nerve. And
Yeah.
below here is the supraorbital fissure. Now, my area for the supraorbital fissure is here. This is inferior orbital fissure. This is supraorbital fissure.
Yeah.
And above that is optic nerve. See the optic nerve coming.
Yes. Yes. Yes.
So this supraorbital fissure is separated from the optic nerve by the optic strut.
Optic strut. Yes.
Optic strut is a bone which is, coming from the lesser wing of the sphenoid
Yes.
to the body of the sphenoid.
Yeah.
That anterior wall separates this optic nerve above from the supraorbital fissure below.
Yeah.
So
Yes.
superior orbital fissure is separated from above by the optic nerve with the optic strut.
Optic strut.
From
Yes.
below with the V2, I mentioned earlier, separated from below with the V2 by the maxillary strut.
Yes, sir.
And this bone, exactly,
Yeah.
let me show this. This bone exactly on the medial wall of the superior orbital fissure.
Yes,
So
sir.
that leaves the carotid artery behind. Only the nerves run through this to come into the orbit anteriorly. See, this is orbit anteriorly.
Yeah.
That was the orbital apex here.
Yes.
That was the orbital apex here, and then it continues here. That is the carotid artery behind.
Yeah. Yes. Yes.
So anterior to the carotid artery, anterior continuation of the cavernous sinus, through which the carotid artery is left behind, and through which the nerves, rest of the nerve, B1, 3rd, 4th, 6th, passes anteriorly into the orbital apex. And that is separated from above by the optic nerve with the optic strut, from below with the V2,
maxillary,
the maxillary strut, and V1 remains in the superior orbital fissure.
Yes, sir.
So
Yes,
V1 and V2 are separated by maxillary strut. So V2 is never a part of cavernous sinus. V2 is never a part of superior orbital fissure. It remains separately in the foramen rotundum running in the floor of the middle cranial fossa.
Yes, sir. Yes, sir. Got the point.
Optic nerve is superior always, and this superior orbital fissure is inferior structure.
Yes, sir.
That you have to understand. This is superior orbital fissure. See here,
this
is superior orbital fissure inferiorly, and here also. Now in the axial plane, if you want to relate, let me tell you, this is axial plane.
Yes, sir.
If I come, see, this is your maxillary sinus.
Yes.
Above the floor of the maxillary sinus, see, this area is the superior orbital fissure, this area. And if I come superiorly, now the optic nerve comes.
Okay.
Below the level of the optic nerve, that
sir.
area of the orbital apex, which is communicated with the, continuation of the cavernous sinus anteriorly, that is superior orbital fissure.
Yeah, excellent point, sir. Very, very, very nicely explained, sir. Hello?
Yes, sir. Sir, please.
Thank you, sir.
Thank you, sir. Thank you very much, sir. The superior one is the optic nerve, and the inferior one will be the superior orbital fissure.
Yes. And they are separated by optic strut.
Okay, sir. Thank you very much, sir. Thank you very much.
Any other question or?
There are actually a lot of questions, but because of time constraints, I think we can conclude the session, sir.
Okay, thank you once again for bearing with me.
Thank you so much.
Thank you so much for your attention.
Thank you so much. Sir. Bye.